Thank you so much, Dr. Manoj, Dr. Purvi ma'am, for giving me this opportunity. And I'll be talking on young onset type 2 diabetes and individualization therapy. This topic is really very close to my heart because I feel if we do something for young population, actually we can change the future. So this is really important. And for the next 5 to 10 minutes, I'll be covering clinical aspects. Most of the theory, biomarkers, and digitalization is already covered by my co-speakers. So I would start with my presentation. So diabetes, yeah, youth diabetes is actually heterogeneous. There are multiple types of diabetes, like type 1, early onset type 2 diabetes, MODY, FCPD, neonatal diabetes, endocrine diabetes, genetics, and gestational diabetes, and others. So today, mainly, I'll be talking about early onset type 2 diabetes, because this is going to be a huge burden in our clinic and in our society. So mainly my presentation for next 5 minutes is I'll be focusing on the early onset type 2 diabetes. So ICMR and ADA guidelines, they've clearly shown that, and we all know that diabetes is increasing, the prevalence is increasing, and the youth onset type 2 diabetes prevalence is also increased by 4.8% annually. And especially why we need to worry in Indians, in South Asians, there is a sharp increase in diabetic patients, especially between 25 to 34 years of age. So it's a huge concern. So there is overall 11.4% increase in diabetes prevalence in India. And youth onset type 2 diabetes has shown 10 times increase in urban centers in last 30 years. So yes, it's the time we need to actually react to bring it down or to halt the further progression. So why type 2 diabetes, youth type 2 diabetes is very important? It is not like adult type 2 diabetes. In this youth type 2 diabetes, it is more aggressive disease compared to the adult type 2 diabetes. There is a faster beta cell exhaustion. There is a longer lifetime exposure to the hyperglycemia leads to earlier complications, and higher rates of nephropathy, retinopathy, cardiovascular disease at an early ages. Plus the psychological impact, because it is happening at a younger age, so still the developmental phase is happening. So kids or adolescents are going through a lot of psychological changes, distress, stress issues. So it's really needs to be handled aggressively and to bring it down. South Asian phenotypes, this article is published by Dr. V. Mohan, and they've shown that in India, we are, or in South Asians, we get the complication at an early, almost 1 decade compared to Western populations. Thin fat Indian phenotype, higher body fat percentage and visceral adiposity despite lower BMI, and we have higher fasting insulin resistance even in normoglycemic levels. Rapid beta cell exhaustion, atherogenic dyslipidemia, higher hepatic fat deposition. So even if we see sometimes there is no abdominal obesity compared to the Western population, but we have higher atherogenic dyslipidemia and metabolic memory effect. So earlier glycemic exposure increases the complication risk. So pathophysiology overview is like same as like type 2 diabetes, where insulin resistance is the key factor. There is adiposity, inflammation is the key factor, where it leads to insulin resistance and beta cell failure. But here the added factor in youth diabetes is it is puberty effect, where the insulin resistance is more, physiological insulin resistance during puberty, which adds to more insulin resistance in the hyperglycemia and more complications. Another thing is greater visceral and ectopic fat deposition. So now we know that we are at risk. So now what we need to do, and I am sure everybody must be doing it, we need to catch them early. We don't need till they come to us and they show symptoms, because 40 to 50% of the patients, they don't show any symptoms of diabetes. So what we need to do is, if the patient has strong family history of diabetes, if the mother has history of GDM, if the patient is overweight or obese, or there are signs of acanthosis nigricans, is the very important thing. I think being a busy practitioner, sometimes we might miss, but we can teach our dietitians, educationists to check for acanthosis. If you check acanthosis, you can detect early patients and you can start them on treatment as early as possible. As per the guidelines, age to begin testing is at 10 years. So 10 years or at the onset of puberty, you should start screening for obesity or acanthosis or prediabetes. And frequency of testing should be every 2 years. GTT is recommended, but I think basic clinical testing, if you see family history is positive and acanthosis is there, then you can ask them to go ahead with the blood test. There is no point in doing GTT for all the patients. And then if you find anything abnormal, then you can go ahead with a normal basic workup, like lipid profile and other parameters. Clinical presentation, diagnostic, again, I said a lot of patients, they are asymptomatic, but the clinical signs, which are skin tags, acanthosis nigricans, is the main thing, which normally we are doing like school camps in Mumbai, so where we go and screen in the schools, where we don't do any random check, just anthropometric measurements, and acanthosis is the thing where we can tell the family or the parents that this child might develop diabetes in near future, so you start dietary changes, counseling, and physical activity right now. So these are the changes you should check. And a lot of patients, they develop diabetes. Along with that, they come with a lot of metabolic other complications like hypertension. Then they might come with dyslipidemia. They come with other complications. So that we need to keep in mind. Yeah, so this is very important slide where I really like this picture, because you forget everything, but just remember this. Whenever you see, suppose the patient is coming to you, but if you see attender is young and attender is having these changes, spend extra 10 minutes and counsel the attender. At least you can save that attender's life. So sometimes they feel, "Arey doctor, patient to main inka kyun time le rahe hain? Matlab, why are you behind him? He doesn't have any problems." So there we need to sit and tell them, no, these are the changes, you work on it, and young patient, you tell them, आप Google कर लो, आपको समझ जाएगा. But when they Google it, they will convince कि हाँ doctor सही बोल रहे. They will not believe us first. So Google if says yes, then they will follow you. So tell them this is really important. In fact, I tell them, you go to your family, just now we had Rakhi festival and all. So I tell them, you check this when you have a get together, and whoever is finding this, you have these changes, please go to your doctor and get it checked. So at least we can prevent pre-diabetes or diabetes occurrence. Simple pedigree chart. You don't need to do hi-fi investigations at the clinic. When you see a first patient coming to you, you just do a clinical checkup, and your pedigree chart will tell you which type of diabetes patient is having, if the patient is coming with diabetes. So when you know youth diabetes, and then you need to classify, yes, for MODI you need genetic analysis, but sitting at your clinic and just spending 5 minutes, you take a family history, draw a pedigree chart, you will know patient lands, he is into MODI category, or he is early onset type 2 or type 1 diabetes. So this is very important. I think I was lucky to work with Dr. V. Mohan. I was a part of his young diabetic registry, and I was working with him in youth diabetes. So it was a routine. Whenever patient comes to you less than 25 years of age, it is compulsory to draw pedigree chart irrespective of the diagnosis. So you need to take the history. So, and this was a privilege that we had written a book on young onset diabetes in children and adolescents, how you're supposed to classify, what are the criteria you should keep in mind, and what type of clinical features, and you can see when patient comes to you. So it's a very simple, handy thing. When you see these criteria are fitting in, so you can see how patient might be having this type of diabetes. Simple. So these are the routine, we know all these criteria. So the guidelines are same for even young diabetes patients. Complication diagnosis, yes, we need to keep in mind, yes, obesity is there, so hypertension check, retina evaluation, nephropathy, microalbuminuria, this you need to check, keep in mind. And whenever you see patient diagnosed for the first time, still you do all the complication workup, even if the patient is coming for the first time. Maybe you take 15 days more, because sometimes they are in shock. They will not accept that they have developed diabetes or they are going to develop diabetes. So you give them counseling time, you give them time to settle down, and then you just tell them it is just the routine checks to screen for the complications, because we can't wait till you develop a complication and then we'll start you on any treatment. So as per the ADA, first and very important thing in management is counseling. You sit with the parents, you sit with the family, involve the family members, explain them what is this, how you are going to tackle the problem. Weight loss is the key if the patient is obese. 60 minutes of physical activity, sports. Even now, I was discussing with my friends, nowadays in school, they will skip PT period and sports period for the academic lectures. So now we really go to school and will tell them that academics is okay, but involve the kids in physical activities, because it is really important. So daily 1 hour of physical activity or sports and nutritional counseling plays a very important role. Start metformin is a first-line treatment. You can start metformin from the age of 10 years, it is recommended. If you see acanthosis, if the blood parameters are abnormal, definitely you can start with metformin. If the HbA1c is more than 8.5, to bring it down, the sugars are high, or if sometimes if the patient is having ketones positive sometimes, then you can start with insulin, and then slowly you can stop the insulin and add GLP for the weight loss. And then third is, again, you need to titrate the dose based on your clinical thing. You can, SGLT is also approved, empagliflozin is approved from the age of 10 years, you can use it. GLP is approved, metformin is approved. Plus, but the main key in this management is lifestyle modification and the behavioral counseling. ICMR again says the same thing, screening recommended BMI if it is more than 23 or BMI more than 25, you should screen. You should start at the age of 10 years. Waist circumference more than 90 for boys, waist circumference more than 80 for girls. You should screen them for diabetes or pre-diabetes onset. Individualization therapy, again, it means that you can't give the same treatment for everyone. You need to understand if the patient is from different background, we don't know. So we need to sit with them, understand their cultural aspects, understand the sociological factors, understand how is the patient financial condition and all, and accordingly you decide the treatment. You can't just tell them you need to start with GLP and if the patient is not affordable. So sit with them, explain them the diet more, and accordingly you strategize the treatment. In young patients, mostly the thing is you need to focus on their mental health. Mental health is the main thing. If you convince them that this is important, definitely they will go ahead with your advices. This is precision medicine. I'm sure Dr. Mohan must have taken in many lectures the thing. It has helped us to just decide the type of diabetes the patient fits in which category, and this helps us to decide the type of treatment will be helpful for the patient. Like SIDD is severe insulin deficient diabetes, there are severe insulin resistant diabetes. So based on the pathophysiologically, it will help us to decide which type of medication will be helping to bring it down, the blood sugars, and to control his diabetes. Is the same thing which I've covered, how you will start with the stepwise manner to treat the diabetic patients. So these are the medications which are approved in young diabetics. Metformin is approved more than 10 years of age. Insulin is, yes, it is approved for GLP receptors, liraglutide and semaglutide, but you need to be cautious. And retina checkup and eye checkup is mandatory before starting GLP-1 receptors for all the patients. And SGLT receptors, again, you can start, but teach them about hydration, inform them about the caution about the fungal infections on the private parts, and immediately they need to report to you if they get any symptoms. This, I think, sir has taken a half an hour lecture on this, technologies and diabetes, and young patient, they are happy when you tell them that we are going to use technologies, along with that we'll be giving you this. So we have a team, what we do normally, we have a team of dietitian, and then sometimes the sugars are very high, and like we had a patient of 180 kgs, 20-year-old boy. So for that, we fixed a device, and then we said, we'll see your pattern. So they're really excited to work on it. They work on their diet, And along with that, we started on with the medication. So technology plays a very important role to show them the results. At the same time, it will be beneficial for the patient as well as for us to decide the line of management. Yes, I think this I've already covered. The psychological aspect and behavioral consideration in young diabetes plays a very important role. So we need to keep in mind, involve the counselor in your team if you have a counseling, or you can offer patient about maybe once a month counseling will help them, or behavioral therapies will help them to bring down their parameters faster. So again, this is a very excellent slide. When you see this, when you have a patient young diabetes and you need to classify which category the patient falls in. So this is, when you see family history is a very important thing. Before you go ahead and doing all the investigations, just family history will tell you how patient is going towards type 1 or type 2. If the patient is going with positive family history, then you see whether it is 3-generation autosomal dominant or it is both parents diabetic. If it is 3-generation, then you can have this patient goes towards Modi diabetes, then you can go ahead with the genetic analysis. At the same time, then if the patient is negative, then you need to see whether it is a ketonuria positive or negative. Accordingly, it is MMRD or it is FCPD or type 1. So this helps you to decide how we are going to proceed with the patient and his therapies. So summary and key take-home messages: youth onset type 2 diabetes requires a comprehensive individualized management plans based on phenotype, risk profile and cultural context. South Asian youth with type 2 present with unique phenotype, lower BMI thresholds, earlier onset, rapid beta cell exhaustion and increased risk of complications. Current ADA ICMR guidelines recommend GLP agonist and SGLT2 inhibitors as early add-on therapy after metformin in appropriate candidates. Technology integration improves outcome when tailored to patient, family circumstances and abilities. Multidisciplinary care team approaches with targeted psychosocial treatment. So these are all references which I've gone through. Thank you so much.